Hello, my name is Patrick Finnegan. I am a science intern at the Cleveland Clinic in the Department of Anesthesia. This year I'll be a senior at Case Western Reserve University, and I worked on a project comparing novel airway technology in patients at risk for airway loss. First, I'd like to share this statement with you. Airway management is a critical component of the clinical anesthesia practice. Direct laryngoscopy remains the most common and fastest way to secure a patient's airway. However, when experiencing a difficult direct laryngoscopic intubation, the clinician should be able to use other means to accomplish the same goal. So the laryngeal mask airway is an alternative airway device that sits supraglottically, and there are many different designs. Archie Brain invented the classic LMA. This device is used to ventilate the airway, but is not considered a secure device because, unlike an endotracheal tube, it does not prevent aspiration. However, it can be used in difficult airway situations when ventilation is necessary, or electively when intubation is not necessarily indicated. Later in airway management history, the fast-track LMA was invented. This device has the normative components of an LMA. However, there's a port where a clinician is able to slide an endotracheal tube and intubate. Thus, the LMA facilitates ventilation, followed by the guiding of the tube through the vocal cords. This procedure is done blind, unlike most direct laryngoscopy, where the vocal cords can be visualized. Recently, the C-trach LMA was invented. This device is an intubating LMA that also permits the visualization of the vocal cords using fiber optics. The clinician is able to position the device in a way so that they can visualize the tube pass through the cords. The advantage here is that the anesthesiologist can continue to ventilate the patient until he has found a position that sets himself up for a successful intubation. So the goal of our study was to compare the fast-track and C-trach LMA for their success rates and speed of intubation. We also looked at the risk predictors for common for difficult airways to correlate them statistically and possibly help guide future research. The goal was to determine if common direct laryngoscopic determiners of difficult airways were the same for these two devices. Our study was reviewed and approved by the Cleveland Clinic's Institutional Review Board. It was designed as a randomized clinical trial where the participants were electively intubated with a C-trach or fast-track. The clinicians were required to have documented 10 successful intubations prior to being allowed to participate in our study. 43 patients were used in our study. We originally planned on 260 patients. However, the C-trach LMA was withdrawn from the market, so we decided to terminate our study. Prior to the procedure, we documented the biometrics of the patient, as well as the difficult airway predictors, such as ASA classification, Mallampati score, thyromental distance, incisor distance, and cervical spine range of motion. During intubation, we used capnography to determine when ventilation was evident and when intubation was successful. And we use these as the start and end times. For the safety of our patients, a difficult airway cart was present for all procedures, and fiber optic bronchoscopy was used to intubate if the assigned device failed 3 times. To select the LMA size, we used the manufacturer's recommendations, which are based upon the patient's weight. For all our patients, we standardized the anesthetic management, and we gave glycopyrrolate to decrease airway secretions, fentanyl to blunt sympathetic response, midazolam for sedation, lidocaine to prevent pain, and propofol to induce sleep. Anesthesia was maintained at 1 MAC, and then a muscle relaxant, either rocuronium, atracurium, succinylcholine, at the clinician's preference, was given. Overall, our sample population had 20 participants in C-trach, 23 in fast-track, and the standard difference between the group fell within the statistical normative values. This means that our groups were statistically similar. This is a breakdown of the ASA grades that were present in our study. And this is a breakdown of the difficult airway predictors we recorded. And these are the outcomes we found from our research. There is a distinction made between when the fiber optic scope was used and when it was not used. Regarding the time to intubation, we found there was a 101-second median difference between the fast track and C track. Therefore, the fast track was faster than the C track. This was not determined to be statistically significant. However, we believe this may be clinically significant in actual practice. Regarding the success of intubation, we found that the C-track LMA was more successful than the fast-track LMA overall, when fiber optic bronchoscopy was not used. And we believe this is because of the time necessary to find the vocal cords, and therefore the anesthesiologist can see the tube pass through the cords. Regarding the difficult airway predictors, the only correlation that was observed with patients was with patients that had decreased cervical range of motion. We found that 4 of the 17 patients with the decreased range of motion failed to be intubated. Furthermore, no other pre-anesthesia assessment was leaked to intubation failures, and therefore, patients having multiple indicators also didn't correlate with failed intubation. Our study is limited by the number of available participants and the withdrawal of the C-track from the market. And the clinicians were not blind to the intubation device that they were using after it was determined before the procedure started. Our recommendation is either for the continuation of our study or for a larger randomized trial so that our results can be confirmed. I would like to take a moment to thank my mentor, Dr. Martua, who for the past 5 years has supported me in anesthesia, as well as Dr. Glenn DeBoer and Dr. Perilla for their assistance in anesthesia education. This summer, I'd like to thank Dr. Ricky Powell for her help with the manuscript, and Gloria Roberts and Linda Graham for helping me obtain the patient records to go through. And of course, all the residents and fellows in anesthesia for their continued support and conversations. And as far as the Office of Civic Education goes, definitely for Rosalind Strickland, Nedra Starling, Brian Flom, and Ibrahim Al-Harti for their acceptance and continued support of my education and research here at the Cleveland Clinic. Thank you very much.